Okay, dear all, good morning, good afternoon, or good evening, depending on where you are in the world. I would like to welcome you to today's webinar, Management of Cardiovascular Risk of COVID-19 Patients, sponsored by Roche Diagnostics Middle East and broadcasted by Informa. I'm Tina Krinjeta-Mićijević, and I will be your facilitator today. We have just a few announcements before we begin. So first of all, this webinar is designed to be interactive, which means that you can find the doc of the widgets at the bottom of your screen, and it should allow you to learn more about our speaker today, to share this webinar via social media, and also to participate in the Q&A session that will take place at the end of the presentation. Towards the end of the webinar, we will kindly ask you to complete our survey. It can be found on the right-hand side of your screen. And please take a minute to fill this out before leaving us, since this feedback will really provide us the valuable information, how we can improve our future webinars and events. And of course, lastly, if you are experiencing any technical problems, please click the help widget, which can be found at the bottom of your screen, or just please type the issue in the Q&A area, and we will make sure to follow up with you and provide you one-on-one assistance. So now on to the presentation, Management of Cardiovascular Risk of COVID-19 Patients. I'm very pleased to introduce our speaker today, Professor James Januzzi. He is the Fatal Family Professor of Medicine at Harvard Medical School and the cardiologist at Mass General Hospital in Boston. So, dear Professor Januzzi, please.
Thank you very, very much. Good day to everyone joining. Good morning from Boston here in the United States, where it's early, but our day is already started. We, like many other places in the world, are currently experiencing the outbreak of SARS-CoV-2, the virus that causes COVID-19. Yesterday in Massachusetts, the little state that I live in, we had 1,050 new cases, which is actually a decrease, but still more than all of the cases recorded in the country of Italy yesterday. So we still have quite a large number of patients that are presenting to our hospitals here in Massachusetts with infection. And I'll talk a bit about the virus itself, as well as the cardiovascular and systemic manifestations of the virus, and how biomarker testing might be leveraged to better understand risk in the infection. And I'll give you some practical tips as well for how one might think about using biomarker testing in this setting. So my disclosures are seen here. Important to recognize I receive grant support from Roche Diagnostics, the sponsor of this session, and I'm very grateful to Roche for supporting this very important topic. So let's talk first about SARS-CoV-2, the novel coronavirus that causes COVID-19, which is the disease, the manifestation of infection. So coronaviruses are relatively large RNA viruses. They're found everywhere in nature, largely in animals, in fact. They are a cause of the common cold in humans, in fact. But most coronaviruses typically are found among animal populations, but then are spread to humans at one time or another. I'll remind you that the original SARS virus was a coronavirus, as is the Middle East respiratory syndrome, MERS. Those are both coronaviruses that jumped from bats through civet cats in the case of SARS-CoV-1, and camels in the case of MERS-CoV. So importantly, and there's been a lot of data recently about the bat reservoirs for these coronaviruses, and tracking the origin of these coronaviruses is a science unto itself. Ultimately, if possible, if there's a change in the genetics or the ability of the virus to infect humans, they jump to humans and then may lead to both upper and lower respiratory tract infections. Most of them are mild. As I said, coronaviruses are often the cause of the common cold. But in this case, both in SARS-CoV-1 and SARS-CoV-2, relatively severe lower respiratory tract infections. So the virus itself, SARS-CoV-2, it's around 38,000 base pairs RNA virus. The way that it is thought to invade the body is through its ability using its so-called spike protein on the surface to bind to angiotensin-converting enzyme 2. So ACE2 is a ubiquitous enzyme found in a number of epithelial cells, notably in the respiratory tract, gastrointestinal tract, as well as in the heart, actually, of course. And it's a key modulator of the renin-angiotensin-aldosterone system. Importantly, unlike some other forms of angiotensin-converting enzyme, ACE2 actually breaks down some of the more favorable angiotensins. So inhibiting ACE2 actually causes a reduction in some of the more, causes a reduction in the breakdown of these favorable angiotensins, which may indirectly be a beneficial thing. And there's been a lot of discussion about whether ACE inhibitor use is either beneficial or harmful relative to SARS-CoV-2. In theory, by inhibiting ACE2, it might increase density of the enzyme on the surface of cells as a compensatory mechanism, which might allow for greater entry of the virus into cells. But on the other hand, by inhibiting ACE2, it might increase the concentration of some of the more favorable angiotensins, like 1 through 9, 1 through 7, which have vasodilatory effects, antioxidant effects, benefits in terms of reducing risk for acute lung injury. So the answer is still unavailable to us. There are randomized trials now looking at angiotensin-converting enzyme inhibitors and angiotensin receptor blockers in patients with COVID-19. Regardless of all of this consideration, the idea is that because ACE2 is present not only in the lungs and GI tract, but in the heart, it is hypothesized that the virus may cause direct cardiac injury on the basis of entry using this receptor. Clinically, COVID-19 presents with a wide range of different presentations. It may be completely asymptomatic in about 1/4, about 25% of people. But when symptomatic, it presents with a typical viral respiratory illness, typical in the sense that it resembles in many ways influenza and other infections, with fever, respiratory symptoms, abdominal symptoms, headache, etc. In severe cases, of course, it may proceed on to acute lung injury and ARDS, and that may be seen typically in older patients, but not only in older patients. We in the Mass General Hospital have seen many younger patients requiring ventilatory assistance. Once infected, patients take around anywhere between 2 to 14 days. Around 5 days is the average before they become symptomatic. So this high percentage of asymptomatic transmission together with the long incubation period is one reason why SARS-CoV-2 has been more successful than SARS-CoV-1, the original SARS virus, as well as the Middle Eastern respiratory syndrome. Both of those became very symptomatic very quickly, which allowed physicians and other clinicians to identify the infection rapidly and isolate. Whereas with SARS-CoV-2, the R0 is thought to be somewhere between 3 to 4 patients. That's the number of patients a person spreads it to, typically during an asymptomatic period. So it explains the ability of the virus to get around the world the way it did. Now, I mentioned that in a certain percentage, the COVID-19 manifestations may be quite severe. These are some early data comparing in 191 patients the manifestations of patients that were survivors versus non-survivors. And you can appreciate that among those patients who died from SARS-CoV-2, from COVID-19, a wide range of systemic manifestations, including heart failure, septic shock, coagulopathy, acute cardiac and kidney injury, as well as secondary infections were present. These are all typical manifestations of patients with severe viral illnesses. We see this with influenza as well. The problem here is the sheer volume of patients that we've been seeing with COVID-19 compared to a typical seasonal flu, where we'll have 1, 2, maybe 4 or 5 patients in the hospital. Presently, in the city of Boston, there are more than 250 patients currently intubated in the intensive care unit with COVID-19. One of the complicating factors that is seen in COVID-19 that was described early on is this phenomenon known as cytokine storm. So among patients with COVID-19, it is relatively typical to see an initial period of infection, viral-like infection. Patients present with cough, maybe some shortness of breath, fever, and they appear reasonably stable. But then later in the course of their illness, in a certain percentage, the development of an inflammatory surge is seen. And in these patients that develop this surge of cytokines, the risk for mortality is quite high. It's not in every patient, certainly, and it's difficult to predict who will develop this so-called cytokine storm. But among those patients who develop it, the mortality is well in excess of 50%. There are currently strategies being developed to identify and treat cytokine storm. And one such way to potentially identify patients either at risk for developing it or early in the course is the measurement of various biomarkers. And that's where we transition over to a discussion around the potential role of biomarkers to help assist in the evaluation and management of patients with COVID-19. So one of the earlier recognitions regarding the potential value of circulating markers relates to the observation that among the organ failures seen in patients with COVID-19 were the heart and the lungs, of course. And I'll show you some older data about the use of biomarkers to evaluate for risk in influenza-like illnesses similar to COVID-19. But the recognition was that cardiac injury, myocardial injury, was recognized among those patients that were subsequently destined to pass away from COVID-19, compared to those patients who survived, who had lower concentrations of troponin. So this opens up a good opportunity just to give you a general spread of possible reasons why myocardial injury may occur. And I will come back to this model very frequently, because I think one of the more important things to take away from this discussion, really critically important, quite frankly, is to recognize that the myocardial injury that is seen in patients with COVID-19, typically manifesting as an elevated concentration of either high sensitivity troponin or natriuretic peptide concentration, the vast majority of it is not related to myocardial infarction. The vast majority of it is not related to heart failure. Indeed, there are ways that the virus may directly injure the myocardium, number one, either through myocarditis or through the cytokine storm that develops in patients, leading to an indirect injury. All of these mechanisms listed are hypothetical explanations for why these biomarkers are seen to elevate in patients with more severe disease. And so it's critically important, as we discuss the role of biomarker testing in patients with COVID-19, to remember, in fact, that the great majority of cases are not myocardial infarction. And this is important because we don't want to go down the diagnostic and treatment algorithm for MI necessarily for obvious reasons in these patients. Now, I mentioned myocarditis, and indeed it's tempting, especially given the fact that the ACE2 receptor is the way that COVID-19 manifests, the way that SARS-CoV-2 invades. And given that ACE2 is found in the heart, it's tempting to hypothesize that myocarditis, myocardial injury from direct infection, might explain some of the myocardial injury. And indeed, there are case reports of myocarditis associated with COVID-19. And so it's possible that that explains some of the patients that present with myocardial injury. Importantly, however, our own experience, which unfortunately, given the many thousands of patients we've already seen at the Mass General Hospital, is that myocarditis, although present in some patients, is not the dominant mechanism to explain myocardial injury in most cases. in most patients that we have evaluated and imaged with cardiac injury, we can't find any obvious evidence for myocarditis. In most cases, we don't see myocardial edema typical of myocarditis. And so although it's an important cause of cardiac injury in patients with COVID-19, there are many other reasons why injury may occur. Now, when we're thinking about who is most likely to manifest cardiac injury, of course, it's the higher risk patients, and who the higher risk patients are tend to be those patients that are older with pre-existing cardiovascular disease. So cardiovascular disease is a critical component to the risk model, if you will, for identifying which patients are most likely to die from COVID-19. And indeed, if you look at those patients that present with COVID-19 compared to and survive compared to those patients that die, we see a substantial difference with a much higher prevalence of cardiovascular disease in those patients that die. So when we look at the overall incidence and prevalence, patients with underlying CVD are around 4% of cases. Indeed, younger patients are more likely to present with symptomatic COVID-19, but those older patients with cardiovascular disease account for nearly 20% of the deaths. And so this is a staggeringly high odds ratio for the risk for death, just really illustrating how there could be an interaction between vulnerability of the host, in this case, a patient with underlying structural heart disease, and acute viral illness. So that gets us to how we might utilize biomarkers in SARS-CoV-2. And I mentioned earlier, there's already a recognition that COVID-19 is associated with changes in certain biomarkers. And the lay press ran a large number of articles about the potential role of troponin in troponin testing in patients with COVID-19, as if this was a new finding. But it turns out, actually, these results are by no means novel. These are data looking at, in the first case, N-terminal proBNP in patients presenting with ARDS, including that from influenza. These data were published more than 10 years ago, just showing that median concentrations of N-terminal proBNP in patients with ARDS and a pulmonary artery catheter to demonstrate that they had normal filling pressures were as high, if not actually higher, than those patients with acute heart failure. So stress cardiac hormones like the natriuretic peptides are abundantly released in patients with critical illness, including those with ARDS. So it should come as no surprise that NT-proBNP release is associated not only with the presence of a virus like SARS-CoV-2, but also in proportion to the severity of illness, much as it is the case for other critical illnesses with ARDS. And the same thing goes with troponin. So these are data that we published, again, more than 10 years ago, looking at cardiac troponin T. This is not the high sensitivity troponin T assay, but once again, ARDS from various causes, including influenza-like illness, was strongly associated with release of troponin and the likelihood for mortality. So cardiac injury, cardiac stress from acute viral illnesses such as SARS-CoV-2, not surprising at all that it's associated with risk. The troponins and natriuretic peptides are not the only markers, of course, that have been harnessed for testing in patients with COVID-19. There's a large number of different laboratory tests that have been measured, and in this table is just a summary of many of the tests that have been associated with the risk for mortality. The take-home message from what we see clinically is that although these tests are frequently abnormal in patients with more severe disease, it is not by any means universal. There are many patients, for example, who have an uncomplicated course that have marked elevation, for example, of their CRP or their ferritin concentration. But on the other hand, the negative predictive value for these tests are all very good. So a patient with low concentrations of liver function tests, low concentrations of lactate, normal leukocyte count, normal platelet count, these patients have a more benign course. And so it is informative. It helps one to understand which patients are more vulnerable to an adverse outcome. But to be very clear and very direct, we really don't know if there are specific treatment strategies that can guide therapy for patients with abnormal lab tests. So it's necessary to emphasize once again that these tests are merely a support to clinical judgment. It's critically important, no matter how much we feel reluctant to be at the bedside of patients with these diagnoses because of the risks of infection for ourselves, we really must be clinicians for our patients and be there for them to understand their disease course. And biomarkers are an important component to this, but there's no substitution for bedside evaluation. All right, so let's talk about the cardiac markers, the natriuretic peptides and troponins. That's really what I wanted to spend a little more time on before we get to the question and answer session. So here are data from the Massachusetts General Hospital. Let's start first with N-terminal proBNP. The blue bar is the median N-terminal proBNP for all patients presenting. This is the initial surge early in our experience. These are data from about 2 months ago. The median NT-proBNP was around 230 nanograms per liter or picograms per milliliter. Importantly, however, those patients that were destined to need to be in the intensive care unit or who were likely to die had a median value of over 300, so 350. So, market elevation for a population whose normal NT-proBNP should be down in the 20 to 30 picogram per milliliter range. Those patients that had an uncomplicated course had a median value of 88 nanograms per liter or picograms per milliliter. And I want you to remember that number because that will come back one more time. So here are data, once again, looking at cardiac injury markers and N-terminal proBNP. These data were from early on in the COVID-19 experience in Asia. Cardiac injury in the form of an elevated myoglobin as well as high sensitivity troponin I, seen in patients more likely elevated in patients with critical disease or severe disease. The same thing goes for N-terminal proBNP. So the early experience would indicate that these markers are higher in patients with more severe disease. And so one then gets to ask the question, well, how might we utilize them clinically? So let's start first with NT-proBNP. These are data from Asia. This is a preprint, so these data have not yet been reviewed. But in this manuscript, an N-terminal proBNP greater than 88 picograms per milliliter. So it comes back to that value that I pointed out in our own experience at the Mass General Hospital, was optimal for predicting the likelihood of in-hospital death. And this cutoff survived extensive adjustment in multivariable models. So what this essentially says is, an elevated NT-proBNP above around 100, even one could use the conventional cutoff of 125, identifies patients at higher risk. But importantly, that's still a relatively low concentration. I think more useful is what you learn from taking serial measurements of NT-proBNP. This is an example of data from Wuhan where patients that were likely to die on the left side had a concentration of NT-proBNP starting around 80 again. And by the time that they were admitted to the hospital from the emergency department, it had increased somewhat. But if you'll notice, those patients that were in critical condition in the intensive care unit, concentrations of NT-proBNP rose even further. In contrast, those patients that were likely to survive had the increase from emergency department to hospitalization, but then as they improved, their NT-proBNP fell. So serial measurements are clearly more valuable than a single spot measurement if you're going to try to judge risk. So at the Mass General Hospital, we take serial measurements of NT-proBNP in our patients with COVID-19, monitoring for an increase in concentration and monitoring for significant elevation. Both are important, but I would say that of the two, the increasing velocity, the rise in NT-proBNP is particularly useful for identifying patients likely to suffer a complication. What about troponin? This is a beautiful summary that Yadar Sandoval put together in a manuscript that we've submitted for publication, comparing the incidence or prevalence of cardiac injury across numerous reports of patients with COVID-19. And what you can appreciate is that on average, it looks like around 20% of patients with COVID-19, excuse me, have cardiac injury in the course of their hospitalization. On the far right, the papers that had more than a 40% prevalence or incidence of elevated myocardial injury markers, these are all manuscripts describing only those patients that were likely to die. So if you look at general populations, depending on the assay, and these are populations including those that survive, it's around a 1 in 5 that demonstrates significant myocardial injury as defined by high sensitivity troponin greater than the 99th percentile upper reference limit. So what can we say about myocardial injury? There's a very nice meta-analysis that was published by Lippi et al. Looking at pooling several studies with cardiac troponin measurements. And what we can say is that those patients with severe disease typically had higher cardiac troponin concentrations. In those patients that had COVID-19, again, about 20% had elevated values, and those with an elevated concentration of high sensitivity troponin were more likely to need non-invasive ventilation, something that we're trying to avoid as much as possible because it causes aerosolization. A substantially greater percentage needed invasive medical ventilation. And again, much like the data that I showed you earlier from our work with ARDS, patients with acute lung injury and ARDS were, of course, more likely to have higher concentrations of troponin. Acute kidney injury, and once again, that association with mortality. In another study, higher concentrations of troponin were once again associated with numerous complications of COVID-19, including arrhythmia, which is an important consideration when we're thinking about some of the drugs we're using to treat these patients, which might be pro-arrhythmic, including hydroxychloroquine. The association with troponin and risk was seen to be in a dose-wise fashion. So the higher the concentration, the higher the risk. And again, I'll show you data in just a little bit that serial measurements are also quite useful for identifying patients likely to progress on. Okay, so our experience in the United States with troponin testing has been unfortunately fairly extensive. And I say this because, as you know, or you may not know, but you'll see in a moment, here in the United States, there are certain areas that have suffered very severe onset of COVID-19 cases. Specifically in the state of New York, and really specifically in the New York City area, as of 4 days ago, there were more than 333,000 cases of COVID-19, which exceeds the total count of cases in many countries in Europe. And there were over 26,000 deaths so far. And that number, unfortunately, continues to rise. So just in the state of New York, and in particular in the area around New York City, there have been more cases and more deaths than in some countries in Europe. And that in the era of integrated health network, data management has allowed for rapid analysis of results from lab tests from many thousands of cases of COVID-19. So these are data looking at high sensitivity troponin I concentrations among patients presenting to one integrated health network. You can once again see that the majority of cases were actually without evidence for myocardial injury, but there's this non-normal distribution with a very long tail where the 99th percentile for this assay essentially is the second bar on the histogram. Essentially from the third bar over are patients with significant myocardial injury. And what we found quite interesting in this analysis is much like the results from Asia and from Italy, patients with a history of cardiovascular disease in the red line were much more likely to demonstrate myocardial injury than those patients without a history of cardiovascular disease. And this is something that I would say about COVID-19, that when you read the literature, you begin to recognize just how, I don't want to call it predictable, but how repetitive the presentations are. So when you look at the reports from Asia, the reports from Italy, from Spain, from other countries in Europe, and what we are seeing in the United States, there's a great degree of consistency in the way that the virus behaves in our patients compared to those in other parts of the world. When we look at the associations between cardiac injury and outcomes, again, much like in the data from Asia, higher concentrations of troponin were associated with the risk for death in all patients, those with cardiovascular disease, and across other risk groups. And you can see, again, it's a dose-dependent effect. On the Kaplan-Meier survival curves on the right, those patients that were below the 99th percentile in green were least likely to have an event. This is mortality. In red, these are patients with mild degrees of myocardial injury, and then in blue, with greater degrees. Now, I mentioned earlier that a rising concentration of natriuretic peptide identifies patients at greatest risk, and the same thing goes for troponin as well. So here, we see the odds of in-hospital death would, in a Wuhan population, rose substantially after about the second week of illness. We see that those patients destined for mortality began to show a rise in cardiac troponin concentration. Importantly, I'll point out that the median concentration of troponin here is actually not terribly high for a high sensitivity assay, but even small amounts of injury are associated with a higher likelihood for mortality. And indeed, these are more data, once again, from another institution in Wuhan, showing how on admission and by hospitalization, non-survivors already show a difference, whereas those who are destined to survive showed a consistently flat concentration of troponin T. So it seems clear that serial measurements of troponin are very useful for identifying risk. And once again, in our institution, in addition to a natriuretic peptide, we also measure serial concentrations of troponin in our hospitalized patients with COVID-19. And this is just one more piece of evidence showing how patients with underlying cardiovascular disease and myocardial injury have a considerably higher risk for mortality when infected with SARS-CoV-2. So cardiac injury, particularly in those patients with cardiovascular disease, is a major risk. So why might that be? Well, you know, again, I come back to that initial very busy slide showing the multiple mechanisms of cardiac injury in our patients with COVID-19. And we really don't know if we can come down to a single reason why myocardial injury might occur. We've seen patients presenting with a type 1 myocardial infarction who had concomitant COVID-19, but that's a small number of patients. We've seen some patients with obvious type 2, so-called supply-demand myocardial infarction. But again, those are a relatively small percentage of the patients we've seen. Interestingly, we've seen a relatively high percentage of patients with stress cardiomyopathy, so-called Takotsubo syndrome, which appears to be maybe more frequent than one might have expected, but nonetheless will be associated with cardiac injury and will be associated with rise in natriuretic peptides. But again, this doesn't explain all causes. Microvascular ischemia, maybe in a small percentage. Tachycardia, maybe in a small percentage. Myocarditis, I've already said, is relatively infrequent, but still a cause. But this gets back once again to the mechanisms that we discussed earlier. There is clear evidence that myocardial injury may occur directly from the severity of illness in these patients, related to cytokines, related to the vasopressors we deliver, related to all of the multi-organ dysfunction that's present in these patients. I mean, if you really take a step back and think about it, if the kidneys are allowed to fail, and the lungs are allowed to fail, and the bone marrow is allowed to fail with thrombocytopenia, leukopenia, et cetera, it stands to reason that regardless of these more sinister mechanisms that might cause cardiac injury, that the mere severity of illness alone may help to explain a lot of the myocardial dysfunction that's seen in these patients. So just to summarize, before we get to more practical aspects, again, myocardial injury, I tell people it's about 1 in 5. People with underlying cardiovascular disease are more likely to develop myocardial injury. When we see this in the 20% of patients that develop it, it is a predictor of disease progression and severity along with risk for mortality. So there is utility for measuring cardiac biomarkers in these patients. And it remains to be conclusively understood how these markers reflect the processes present in COVID-19. But once again, it is far, far more complicated than simply saying these patients have a myocardial infarction. And that's a critically important thing to start considering. So the big question comes up, should we be testing our patients if we don't understand the mechanism of their release? What are the risks? What are the benefits? Well, let's start with the benefits. The benefits are that we identify patients that are more likely to be at risk. And is that not a good thing? Chris Mills, a good friend, Nick Mills, a good friend from Edinburgh, published a provocative article in Circulation challenging the conventional wisdom that sort of dictated that we shouldn't be testing troponin. And Nick's argument is it's important to identify patients at risk. And I agree with that, actually. I think that it's important to know as much as we can about our patients. It may also help us to develop further understanding and knowledge of the consequences of COVID-19. Possibly, if utilized within the framework of decision-making that incorporates the biomarker result, it may facilitate appropriate triage. I must admit that, it's a big leap. It's a big difference to go from simply measuring a biomarker to using the result. And I think that's one of the biggest concerns that people have said is you can measure the marker, but how do you respond to the result? And this gets to the concerns. The frequency, about 1 in 5, and the nonspecific nature, the reasons why troponin and natriuretic peptides are abnormal remain somewhat unclear, worries many people. Because if a person sees an abnormal troponin or a rise in natriuretic peptide, what is the usual response? The usual response outside of COVID-19 is to call a cardiologist consultation, to perform imaging, to perform stress testing, et cetera. And this is a concern because this so-called cascade of events or cascade testing has already been seen in COVID-19 as a result of biomarker testing. So one needs to take a step back and think very carefully about why we are measuring these tests. Indeed, 2 international societies, the European Society of Cardiology and the American College of Cardiology, have both come out and said that routine measurements of both BNP and NT-proBNP as well as troponin should be utilized mainly for the cardiovascular applications. And this is really what led to Professor Mills' article in Circulation to challenge this logic. And again, I understand both sides of the argument. I actually wrote the American College of Cardiology text. The issue here is for us to think very critically about why we are measuring these tests and use the test within the context of why you're measuring them. In other words, if you're testing troponin to look for an MI, you're going to find a lot of injury in these patients. that is probably not related to myocardial infarction. And the consequences could be dire if you order echocardiograms and other tests that expose staff and others in the context of the testing. On the other hand, if you're ordering the test to better understand the course of your patient with COVID-19, that's a logical application. So once again, the pros and cons about whether to test or not relate to the fact that there is concern about cascade testing. On the other hand, the clinical course of COVID-19 may be very difficult to predict, and having that unique information may be useful. And this is the logic by which we at the Mass General use both high sensitivity troponin T and N-terminal proBNP. We aren't testing to screen patients for myocardial infarction. We're utilizing it as a measure of disease severity and prognosis in our patients with COVID-19. And so this is a proposal, which is to say that absent signs or symptoms of acute myocardial infarction, patients with myocardial injury very likely have a primary non-cardiac illness and therefore do not merit the cascade of tests that one necessarily would order should a patient have a suspected or proven myocardial infarction. So the possible diagnostic approach would be, again, history and physical at the bedside. Standard biomarkers at the MGH, we test troponin, natriuretic peptides, C-reactive protein, ferritin, and D-dimer. It's the five-fingered approach, the 5 tubes in the hand there. Typical radiographs, chest radiography, electrocardiography. In the presence of evidence of myocardial dysfunction, not injury, but dysfunction, if a patient shows rising natriuretic peptides, rising troponins, signs and symptoms of worsening clinical status, we will start with a point-of-care ultrasound, a point-of-care transthoracic echocardiogram, reserving a full or somewhat limited echo using a formal technologic approach for those patients with evidence of myocardial dysfunction on the point-of-care ultrasound. Absent those findings, absent progressive cardiac dysfunction or evidence for more obvious thromboembolic complications or other signs and symptoms, we will continue to monitor with a restriction on the amount of imaging that we do in our patients. This is in part to protect our staff, to reduce the risk of contamination of imaging technology, and also due to the fact that the likelihood we will find an actionable finding is small in the presence of a non-progressive clinical picture with low or non-rising biomarkers. So in conclusion, ladies and gentlemen, thank you for joining this afternoon, wherever you are. COVID-19, the manifestation of the novel SARS-CoV-2 virus, is a systemic inflammatory infection, multi-organ involvement that causes around 20% or more, depending on the population, evidence of cardiac stress and imaging. We use numerous biomarkers in our patients with COVID-19, including hematologic, inflammatory, thrombotic, and cardiac markers. Again, of course, we get a complete blood count in our patients, but we check CRP, ferritin, D-dimer, and NT-pro, and high-sensitivity troponin. Abnormalities of NT-proBNP and high-sensitivity troponin do not necessarily reflect heart failure or acute MI. And in fact, the majority of cases are not heart failure or acute MI. They're direct stress and injury from the systemic inflammatory disorder that is COVID-19. Marked elevation and rise in either marker may support clinical judgment, implying involvement of the cardiovascular system. In those settings, decision-making regarding triage may be helped and may also be useful to make decisions about management, including imaging. I think also it's necessary to once again emphasize the negative predictive value when the markers are low and stable really helps us to triage away from imaging in patients that otherwise may not merit it. So this is, we find utility, but really important, much like what the national societies have argued, it's important to really think carefully about why you're measuring these markers and how you'll use the results. So I will stop, and we have some time for questions now. I would encourage you to send questions in. I'd like to thank you very much for joining this session today, and I want to thank Roche Diagnostics for supporting it. Thank you very much.
Thank you. Thank you very much, Professor Januzzi, for really an excellent presentation and really having the opportunity to see the latest data as well as to summarize the ACC and DSC recommendation. So maybe let's proceed, as said, to the Q&A. Just as a small reminder, please type your question in the Q&A text box that is located on the right-hand side of your presentation window, or just use the Q&A icon at the bottom of your screen. And of course, if we don't have the capacity to answer your question, we will for sure follow up offline and be sure to follow up with the speaker and reply to you offline. And just a kind reminder to also fill the survey before we leave. So let's maybe start with the questions. So before we proceed, just a short question, Professor Januzzi, from my side. So what would you see maybe as a main reason why ACC and DSC guidance documents discourage the routine measurement? I think you presented your, yeah, please.
Yeah, it's a great question. I can tell you there's a simple answer, which is it was an early response to the recognition that cardiac injury was commonly seen in patients with COVID-19, and people really did not understand why it was happening. And a lot of testing was being done in patients: echocardiograms, cardiac CTs, cardiac catheterizations, MRI. And this leads to an unnecessary exposure of staff in many cases. So because these societies are member-driven and think of the members first, it's about protecting membership, right, from making a mistake in how they're approaching patients with evidence of myocardial injury. So my feeling about it is it's an opportunity for education, and it's likely that these recommendations will change as we have a better understanding about the way to best manage patients using these biomarkers. What I can say is that, once again, in our institution, we're not testing troponin to look for myocardial infarction, right? But in some institutions, that's what it was being used for. And what happens when you see a myocardial infarction is you go to an angiogram. And so, you know, until we have a better management strategy, and those are being developed now, it's just a reminder to be careful.
Yep. And then maybe just two more things. I think you emphasized, and the literature showed that there is a cytokine storm as a potential mechanism for development of myocardial injury. So would you see, and what is your experience, would you see the value of measuring IL-6 in this context together with cardiac biomarkers?
Yeah, it's a great question. We reserve IL-6 measurement for our more critically ill patients because there is some hypotheses that blocking interleukin-6 using specific IL-6 blockers, tocilizumab and others, sarilumab, might reduce the risk for death in this setting. And so we're measuring IL-6 in part to identify patients eligible for randomization in trials looking at this question. I think it remains to be seen whether this adds to clinical decision-making above and beyond the natriuretic peptides and troponins. But, you know, as you know, many people are looking at this question now, so we'll hopefully have an answer soon. If there's one positive coming out of the COVID-19 pandemic, it's that everybody's working together, and there are so many cases worldwide. It gives us an opportunity to rapidly identify potential strategies for evaluating our patients.
Yeah, excellent. Thank you so much. And what about the D-dimer? I mean, we saw that the thrombosis is described as a major complication. So what would be the role of D-dimer in evaluating these patients?
Yeah, as I mentioned, we measure D-dimer in our patients, and D-dimer is a way of identifying activation of the thrombosis and hemostasis system. Elevated concentrations of D-dimer have been associated with mortality in COVID-19, and so we do measure it. The association between D-dimer and thrombosis is a little less strong, actually. So we have some patients with D-dimer concentrations in the many thousands, and we don't see clinically obvious clot. However, it is definitely the case that COVID-19 is associated with thrombotic complications in certain cases. So more information is needed to best understand how to interpret the changes in D-dimer. Much like with many other cases of systemic inflammatory response syndrome, we see activation of disseminated intravascular coagulation with elevated D-dimer. So it may or may not identify the presence of clot, but we are doing trials now with anticoagulants in these patients to see if it changes prognosis.
Great. Thank you very much. Let's maybe address some questions also from the audience. So the question is about cardiac arrest. So can COVID-19 be complicated with the cardiac arrest before any COVID symptoms appearance?
Very important question. The frequency of sudden cardiac arrest went up dramatically in the city of New York during the initial days of the COVID-19 surge, and the same has been seen in other countries. And the question is whether this is related to the death from cardiovascular disease where a patient had symptoms but was afraid to come to the hospital, right? Because they were afraid of getting COVID-19, or was it a manifestation of COVID-19? And the answer is it's a mixture of both. There are examples of people who died suddenly at home without symptoms who were then on postmortem found to have COVID-19. So cardiac arrhythmia is certainly a possibility from myocarditis. Again, although not that common, thromboembolic complications in early COVID-19 may also occur. So pulmonary thromboembolism also is another potential mechanism. So yes, that can be an early manifestation.
Yeah, great. Sorry, I just saw also one great question. Okay, so what is the cutoff value for high sensitivity troponin considering the management of COVID-19 patients with the potential for myocardial injury? And what would be the interval for the serial measurement that you would recommend, or there is, let's say, recommended by their experience?
That's really helpful. There are a few questions about that I see. So we measure it every day, once a day. And we use the 99th percentile for myocardial injury. But importantly, I would emphasize, look at the number. Don't just use the 99th percentile, but look at the change over time. That's, I think, more important. And look at the absolute concentration. A small bit of myocardial injury that is just slightly over the 99th percentile is less concerning to me than is a rising concentration. And for NT-proBNP, we use 125, and we measure it daily.
And then there is a question, I think, for more mild cases. So, do you recommend testing high sensitivity troponin and NT-proBNP in patients admitted to the hospital with more than mild COVID-19? And again, how frequently would you monitor it during hospitalization?
So what was the question? I'm sorry, Tiana.
Yeah, sure. So basically, if you have the patient who is admitted to the hospital but with more than mild COVID-19, how frequently should you measure the cardiac biomarkers, high sensitivity troponin and NT-proBNP during the hospitalization period? We typically measure it again daily. And if a patient is improving, we may stop measuring it at that point, But importantly, I think that it's necessary to emphasize that if a patient is improving, it doesn't mean they're out of the, as we say in English, out of the woods yet, right? And so, if we see a rising natriuretic peptide or rising troponin on their daily measurement, if they've got, say, moderate disease and they seem like they're getting better, but their markers continue to rise, we will continue measuring, right? But if the markers are starting to drop and they're improving, that's when we will typically slow down on their testing. Usually they go home at that point. Yep. And then I think, okay, maybe, yeah, a question regarding the coronavirus. Is it true that coronavirus underwent the genetic mutation that made it much weaker than it started? The virus has lost the ferocity 60%. Yeah.
Yeah, so thank you for that. So I'm not a virologist. All I know about mutations in SARS-CoV-2 has to do with what I've read. If it's weaker, you could fool us here in the United States. I mean, we've got, many millions of cases now with a substantial mortality risk. It is true that there have been actually several mutations identified in the virus, none of which really appear to be a shift or natural selection towards either a stronger or weaker virus. If anything, it looks mainly like what's called a founder effect, which is that a mutation occurred in a specific region, in this case, Europe, that then led to spread from Europe to the United States. Most of the infections in the United States are actually related to spread from Europe, not Asia. So I don't think that this necessarily reflects a change in virulence, either to the worse or to the better. I think it just represents a shift in the genomics of the virus. Quite fortunately, at least, it seems, based on early experimental data, that a vaccine may be able to be developed against the virus, regardless of these changes in its genetic material. So we shall see if we're able to develop a vaccine that will be immunogenic for the larger population.
Mm-hmm. Yeah, great. Thank you so much, Professor Genuti. And how about, I think I saw also one very nice question. So what are the CVD consequences that can be expected in the long term of these patients? I mean, we saw the data that most probably they may have the more challenging course of recovery and then the long-term consequences. So yeah, what could be the expected consequences, and maybe where do you see the value of biomarkers to monitor and manage these patients? Professor Januzzi, we cannot hear you.
Sorry about that. Yeah, I was clearing my throat, and I muted myself. So it's whoever asked that question, it's a really important one, and thank you for asking it. So we're writing a paper right now on this exact topic, which is, looking into the future. How do we monitor patients after COVID-19? And the reason why I say this is an important subject is because we have experience. If you look at those people who have recovered from SARS, the original SARS-CoV-1 infection, and to a lesser extent, but still with MERS as well, in both cases, patients have around 20% of the time a chronic cardiopulmonary syndrome with shortness of breath and other longer-term consequences. And so it's generally mild, but there are patients that develop cardiomyopathy from recovered, either fibrosis, injury, myocarditis, or other mechanisms that we don't understand. And in those patients, biomarker testing, particularly with the natriuretic peptides, may be quite useful to understand the symptoms, understanding if it's the lungs or the heart. And so we're actually going to be recommending in this article we're developing, a strategy for screening patients after recovery from COVID-19 to identify persistent cardiac dysfunction.
Yeah, great. Thank you so much. And maybe just potentially connected to that, in this COVID pandemic, most probably you saw the effects on the outpatient management of CVD patients in general. So do you see maybe potential value of biomarkers that can help outpatient management of these CVD patients in this pandemic?
Yeah. So for us, and I know for everyone else, when you're in a shelter-in-place, lockdown, it's very difficult for us to take care of our patients, and so we have been, for our heart failure patients, for example, doing a much larger frequency of home biomarker testing. We send nursing staff to draw blood in the home and we monitor their NT-proBNP concentrations as part of their virtual visit. So after I finish here today, I'm going to be shifting over to doing virtual visits with the same camera with my patients, and they will provide me their vital signs, their weights, their NT-proBNP value, and then I'll be able to, as best I can, manage them while we're in this awful situation. Many people probably know there's a lot of interest in near-patient testing and home testing, and we're in the process of developing a home finger stick method for testing NT-proBNP that'll be in front of the FDA very soon. And so this may help to facilitate home management of patients with heart failure even after the lockdown is finished.
Yeah, thank you so much. I think we got a warning, basically, that's all the time that we have for the questions today. So I will make sure that we follow up with all unanswered questions and answer that offline. I would like to thank once again to you, Professor Januzzi, for really an excellent presentation and sharing with us the latest data and having this fruitful discussion. And of course, I would like to thank to all participants that took a time and joined us for this webinar. And we are very much looking forward to seeing the next webinar in this series. And until then, I wish you to stay safe and healthy and all the best. So goodbye from my side.
Thank you very much. Thank you for having me, and stay safe, everyone. It's very nice to be speaking with you today.